I I'm Chris Newcomer, and most of you know me from this project actually more than the work with the Cancer Alliance. So I am one of the project managers of the Breast Cancer Gaps Project, and today we have two of my favorite people who are presenting. We are a group that's been meeting for about a year, no, 2 years, probably, me, doing this project, and the whole focus of the project is putting the lived experience of Black women at the center of solving the problem of the 41% mortality rate, which our whole focus is that is an unacceptable mortality rate, and what can we do in a community-based setting to make change. And we have done a lot of stuff. You can reach out to me afterwards, and I'm happy to direct you. We have videos starring Dr. Soma on myths and what to expect and all sorts of things. That our project is community owned and community-led and community-run. So we have a directorship of 6 Black women. LaShonda is, Dr. Soma is one of them. Okay, just call you LaShonda. And 5 other women who really help us, tell us, my partner and I, what to do. So with that being said, I'm going to introduce two, as I say, Dr. LaShonda Soma. She is director of the Regents Breast Center. She is passionate about this issue, and for us, she's brought a lot of that experience in the radiation in the center. What are the issues? What do we need to focus on? So she will be talking. And then we have Jess Roberts, who is a community design facilitator. He has a company, Culture of Health by Design, also works for the U. And when we were looking at how do we take this stuff that we know, this survey information, and make change, serendipity brought us to Jess to really learn about can we use this model, which is different than a standard public health model, pilot program, evaluation, and then 2 years later you might have a project. This is a really quick kind of rapid prototyping project. And so we've used this model, and we are still using this model in developing our next set of projects. So with that, I'm going to turn it over to Jess, who will talk about the co-design process.
Thanks, Chris. Is this working? Good, all right. So I want to give a little bit of background first on what is co-design. I know Dr. Cunningham mentioned community co-design and sort of moving beyond just sort of a traditional engagement approach. So give a little background on that, talk a little bit about high level, some of the priorities that came out of the GAPS project, and then LaShonda can share some of her direct experiences and sort of priorities from that work. So co-design, more than anything, is just looking for ways to place people most closest to the problems, most impacted by the problems, in some decision-making capacity. So many of you have seen the sort of spectrum of public engagement. It is more in that sort of partnership collaboration space, where what are the real opportunities to influence an actual outcome, to influence the environments, the policies, the practices that I am living on a daily basis? How can I have a more active role in that? Which also includes things like so shifting some of that decision-making power, but also some of that financial component as well. So compensating community co-designers as professionals rather than, yes, community narrative, community experiences matter, but you just need to show up because you care about it, and everyone else on the team shows up because we get paid to be here. So also shifting leveling that playing field, because it's really difficult to have a conversation about equity when the elephant in the room is we're not being compensated in a similar fashion. So really showing it in not just the process, but the compensation that is included in the process. So traditional community engagement, and I think Dr. Cunningham also pointed to this, you start to tap into your usual suspects. It's the people that are going to show up no matter what, and a lot of times bring their own agendas that might not be all that reflective of the communities they're part of. It's also a pretty significant burden to place on someone to be sort of a universal token representative of a really dynamic community that they're part of. So we tend to do that. It tends to be a lot of one-offs. We tend to focus on how many people we connect or engage with rather than the quality of the data or information we're gathering in that process. So we can tend to have, we talk to 500 people, but you kind of have the same conversation. It's really quick, really shallow. You don't get much of the context. It's just sort of the same information, really high level. In the community co-design process, we're looking to sort of get that tier deeper. So get beyond the usual suspects, and this includes in the recruitment process. It's an active, proactive recruitment process to identify individuals that will be part of that process because they bring access to communities that we tend not to hear from. So we engage with community organizations not to be the co-designer, but to help us identify individuals that might be a good co-design participant. The focus in that process is a smaller cohort of folks, so 7 to 9 individuals that then can reach, that aren't not only bringing their own lived experience, but more importantly able to access and connect with neighbors, coworkers, friends, family members, to be able to bring forward experiences, to bring forward insights that wouldn't be accessible otherwise. So the people we just reliably don't hear from because of a lack of trust, because of a array of barriers to participate in these things, aren't interested in, submitting a survey, aren't going to show up to listening sessions. That's a large chunk of the population we just reliably don't hear from. And then I think equally or even more importantly is not only are these conversations happening in the community through what already is a trusted channel, so able to have a really different kind of conversation, but the co-designers themselves are the interpreters of that information. So one of the challenges that we often see in engagement strategies is we'll collect a lot of interesting, meaningful, lived experience and information, but then the usual suspects will interpret that information. And those usual suspects tend not to share that lived experience lens, so it tends to be, well, not sharing any of those lived experiences. Here's what I think is important. Here's what I think these experiences are telling us. And it's usually from the lens of like, well, what does our institution or organization already offer, and how can we convince people to utilize those services, instead of people that are closest to this, that are part of these communities determining what's important, what do these experiences mean. And so I think that's also a really critical part of this process. And I think another thing I should note is that this isn't research, so it isn't about what's the statistically significant sample set. It isn't about, well, you shouldn't talk to family members because you have a relationship and that might skew your data. Like, this is about exposing those biases that have really not been part of the design process in the past. We tend to always talk about controlling bias, but we know bias makes its way through, and it's usually one set of biases that determine how these programs, policies are developed and implemented and tested. So this is about exposing some of those biases that have been missing in the past. So like I said, it's also important not to just have these one-off sort of interactions with folks. This is a sort of illustration. Chris mentioned that iterative process. So a co-design project, co-design efforts tend to have multiple iterations. And then within each of those iterations, we have that co-design team coming together, sharing their experiences, sharing what they heard from their conversations, and then going back out. So the sprint bubbles are where they're going out, having these conversations with folks in their own networks. We will usually offer some guidance in terms of like, here's the types of questions to ask, but people can sort of adapt that. They can ask the questions they want to ask, prioritize the types of questions they want to ask, and then bring that information forward. And in this way, it allows us to sort of learn our way forward, and it's a structure for following the lead of the community itself as much as possible. So really, the only agenda that we ever set is that first session, and then beyond that, it's what did we hear, how might we prioritize those things, and how might we sort of get deeper and learn more about those things. So when we hear things like, an example might be, well, I just don't feel welcome when I go to this clinic. Well, usually that'll mean, well, we just need to design more welcoming clinics, and then usually it's the leadership of the organization that determine what welcoming actually means and looks like. Or we can really start to unpack, what does welcoming mean? Where are people going now where they feel welcome, where they feel heard or seen? What does that mean? How does that show up? Also, when we talk about things like access, right? Like, access is a really generic term, and we tend to think of it in a really overly technical or transactional way, but usually there's other things underlying those, what access means. And so this is that opportunity for us to really better articulate and contextualize what things like welcoming or access might mean and look like, as well as prioritize those things. Because a lot of things will come out of the work, but not everything is going to be a priority. And so this is also a bit of that art of what matters to community, and then what do we have real opportunity to influence? Because if we can't attach it to anything, then we just continue to have interesting conversations with community that don't see anything on the ground actually ever change. And so it's that productive tension that we call it, where it's meaningful and matters to community, and there's an opportunity to actually influence and impact the outcome. So that's what we're constantly trying to hold through this process, and it may take 10 iterations, it might take 2 iterations, it depends on the issue, it depends on the community you're bringing together. In this project specifically, we had 4 of these iterations, and then we worked with the co-designers to further refine what are those prototype opportunities, which is basically getting something real into people's lives that they can react to, respond to, before you fully bake an idea. So this process is about really exposing those assumptions that we almost always have going into projects before we bake them into some large-scale, expensive pilot, and only then, after 6 months of investment, start to see these feedback loops that aren't all that positive, and we can't actually do anything with it anymore because we're over-invested. So this process is about being really agile, exposing the assumptions that we don't even know we have early enough in the process that we can actually inform and influence the actual outcomes in a meaningful way. We can incorporate the lived experience in real time to actually influence the outcome. And so I'll share just really high level, there's sort of 3 priorities that came out of the GAPS work in bringing together. The other thing I should mention about the co-designers when we bring folks together is really paying attention to bringing a diversity, so capital D, diversity, diverse group of folks together that are going to obviously bring diverse cultures and race together, but also gender identity, geography, age, thinking about physical, mental ability levels. So really thinking about that diversity, not as like, well, it's the right thing to do, which it is, but that's where creativity actually emerged. And Dr. Cunningham touched on that a little bit in her conversation of like diversity of ideas is where creativity is born. Creativity by definition, if you look at research around creativity, it's not new ideas, it's not the light bulb moment, that's a fallacy. It's actually bringing diverse experiences and perspectives together in new ways. And so the most straightforward way we can do that is just be really intentional about bringing those differences together. If you're in a room where people are agreeing, this process isn't about developing consensus, right? We shouldn't have consensus. If you're in spaces where there's universal consensus, you don't have the right set of people around the table. It's just everyone's coming from the same background, trained in the same ways. You should never have universal consensus. You should look to get people closer together and be in a productive space. But instead of being proud of developing consensus, it should be who's missing from this conversation or who doesn't feel safe enough to share their different perspectives. And so in this process, three of the priorities that came out of this, the first one was this sort of notion of a front door. And Dr. Cunningham also talked a lot about trust in relationship. And this is no different, right? Like, people don't trust organizations. No matter what your organization's mission statement says, people don't trust it, right? They trust other people they know. They have those relationships. They've had the opportunity to build trust, that don't have agendas, right? That's who they trust. So this is about recognizing what are those front doors for folks, particularly for folks where the system wasn't designed very well for, or at all, to serve, right? So when we talk about things like access, again, that isn't necessarily that there's a healthcare desert. Like, maybe 100 clinics in the community may still not bring all that much value, because the way the clinics operate, the fact that you have to go to the clinic, may be the problem in the first place. So that's like getting an understanding of what access means. And in this conversation, it was, you know, what are those trusted, reliable entry points for learning about breast cancer screening, for understanding the value as well as what that process is like, tended to be the people, right? So participants talked about schools and daycare, so reliable places where young and middle-aged women were reliably showing up on a daily basis. Faith communities, I know in the past, looking at barbershops and nail salons, so where there's not necessarily the agenda of health as being a trusted access point, not just to say, here, push my message, but like design around what built that trust, what is behind that, so we can design messaging and support that actually reflects those things, so it's not just about dictating, well, tell people that breast cancer screening is important, right? Well, no, what's behind that trust? How do you talk about health more broadly, right? Like, how does it come up? So that's the setting in which you have that conversation. It isn't, here, pick up a great shiny brochure that we've tried to wordsmith for the last, 8 months. It's the conversations, it's the connections. The other thing that we've expanded on now, that was a interesting insight from the first iteration of this work, was the role that men, particularly partners of African American women, play in their own health conversations, in screening and things like that. So we're currently in that process of working with African American men, whether that's a spouse, whether that's auntie or a grandparent or sister, looking at what role does what is the family unit approach to having conversations about, obviously, breast cancer screening for this purpose, but health more broadly. Because what you see pretty quickly is that particularly mothers tend to devalue their own health pretty significantly and prioritize the health of everyone else around them, even pets, before themselves. So Dr. Cunningham being a great example of, 8 months in, waiting for, that colonoscopy, because you're prioritizing everything else and everyone else before yourself. So really exploring what role does the other family members play in this conversation. So part of that conversation is the normalizing and raising awareness. So one of the biggest barriers that we talked about was sort of, one, if this isn't just a normal conversation you've had growing up, right, about screening or breast cancer screening specifically, it's not top of mind, right? I've done projects with researchers in like colorectal screening, for example, and they think about screening your colon every day of their life, but most people do not, right? So really understanding, how do people talk about health in the family unit? What does that look like? How do we, and the other key barrier was like, what is the process like? Where do I even go to schedule something like this? What age do I need to be, right? even if you're on top of the research, that age question is something that's constantly evolving, and what's covered by insurance or not, and by which insurance. What does the lead-in look like, right? What does the procedure itself look and feel like? What does follow-up look like? And so one of the most persistent barriers to actually doing these things is not knowing, right? Not knowing is one of the greatest human fears, and that shows up because, well, if I don't even know where to go to do this, like, you're just not going to. So in this work, we looked at how do you help illustrate this? Sometimes in, conversation with those trusted, the front door channels. Sometimes it's, I need some illustration of what this actually will look like. Sometimes it may be actually walking you through the process without having to do the screening itself, but walking you through that process as a whole, because I need to feel it, I need to see it, and that being a significant barrier for folks that I just don't even know. The not knowing, and then obviously the what happens if they find something, right? So that follow through that Dr. Cunningham was also talking about. And then finally, and also these are all through this process, it's sort of trying to identify unique themes, but recognize they're all obviously really intertwined and interconnected in some way, and really built on that human-centered, the people matter, the relationships matter, and that's what you need to design around. It tends not to be, well, we just need to push out more information, right? Because sometimes the more information is actually more problemsome, right? Here's more resources. Great, I have more homework to do, right? And that's where the advocacy and empowerment sort of conversation comes from, is self-advocacy. We always talk about advocacy, advocate for yourself. And yet we're telling people, particularly in this situation, to advocate for something, within a system that probably wasn't designed for them in the first place, right? So advocate within the system that doesn't meet your needs or doesn't relate to your priorities, lived experiences, hopes, fears, and values, right? So that's a problem in the first place, because additionally, we put the burden on you to be the advocate for yourself, right? Within this unknown space. That's when we talk about patient burden, that's we're telling you to do something you have no knowledge of doing, and just do it, right? Advocate for yourself, particularly within an environment where you maybe have shared these things in the past and they've been devalued by the system, right? So this really recognizes that, what's that proactive way? How do we design systems that actually are built around, that start with lived experience and those values, that maybe aren't about going to a clinic, right? That maybe are about what is, can we do group screening sessions at a child care or a school where this target audience already exists. We have to really, Dr. Cunningham talked about that too, right? It's often not just the logistical, technical, high-tech stuff. It's that other stuff that we aren't doing well. We're not meeting people where they are. We always talk about, well, we need to meet folks where they are. That doesn't mean just geographically, right? This means delivering in a really different way, designing systems that actually reflect and start with hopes, values, fears, and connect through where I already have those relationships. Otherwise, we always talk about persistent disparities. Again, wow, we've been pushing out the information. We've been educating. Well, we've been educating within a system that people don't have the trust, don't have the connections to start with. So you need to sort of that outside-in design, where you're designing around the reality, not what we hope the reality is. So with that, we'll take questions at the end as a whole, but I want to make sure LaShonda has time to share sort of her experience and sort of takeaways from the work and conversations that she had.
Hey guys, I'm LaShonda Soma. I sit and talk to patients all day, so I'm far more comfortable sitting and having conversations than I am standing behind a podium. So just a little bit about me and how I got into this work is so I'm a fellowship trained breast radiologist, and I'm the director at Regions, but have a lot of experience in the breast cancer world, even personally. My mom had breast cancer, my aunt and my uncle all have breast cancer, and throughout that journey we found that we have the BRCA gene in our family that predisposes us to breast cancer. I carry that gene. In 2012, I had a prophylactic mastectomy myself, and every day I work with women in breast cancer screening and diagnosis. So kind of feel like outside of having cancer myself, I had seen this from almost every angle that one could see it from. And even so, having become a part of this group, I learned so many things that I could not have learned otherwise, just from talking with groups of other women who had other experiences, and to have honest conversations about breast cancer, screening, why people don't talk about it, why people don't come in. We don't have all the answers, but it was really nice to just chat about it. As a physician, you know, they send out these surveys after you go to your doctor, but we never get to get real feedback about how patients feel about us. Sometimes you can sense it, but you don't get a lot of feedback. And one of the themes that I heard over and over again as we did these interviews in the community and also talked to each other was this sense that people felt like their providers didn't care about them. And I know a lot of doctors, and I can tell you 99.9% of them care deeply about their patients, but is that translating? And what Jess was talking about, patients feeling like they need to advocate for themselves, what I heard a lot was people coming in with the expectation of what they needed or should get medically. And when that expectation was not met, their takeaway from that is that the doctor didn't listen or didn't care. For a lot of women, you may just say, I'm going to go to another doctor. But what we find is a lot in Black women, they just disengage totally from the process and say, well, that's exactly what I thought. They don't care about me. And the negative impacts that may come from their health care from doing that. So one thing I learned was, just personally as a physician, how to show that I care and make sure that patients understand that I care, even though they're not necessarily getting the test that they thought they should be getting or a biopsy when they didn't need one. And so I think that's one thing just personally in this project that I learned, and that I think will be important from a healthcare setting for us to further understand. The other thing, just to piggyback on what Jess said about organizations, people don't trust organizations. It doesn't matter what type of, mission you have. One funny story, when I first came onto the project, another lady who actually works at Health Partners was saying, yeah, we did this skin cancer screening and we were trying to bring in minorities and we even offered $100 gift cards. And I was like, oh, I'm sure nobody came to that, because the first thing they think is, why are they giving you $100? What's in it for them? And she's like, oh, we just never thought of that. But that's one of the fallacies of coming as an organization, think you're going to present it, you build it, they will come. And it just doesn't work like that. People trust people, like Jess said, and how do you get into the community? And part of that is starting with the community when you're designing your project. So I think this has been very refreshing to be a part of this, because every day in my professional life, I am just dying in red tape of trying to do even the smallest change. Something that I see every day that would be immensely helpful to my patients, and I have to run it through 8,000 departments, people who have no idea, to try to get it done. This was so great because it was kind of just whatever we wanted to do. And whatever direction that the information that we were getting led us to. And also refreshing to not have to justify the outcome. People say, well, how will you know if it's working? I don't know. Whereas sometimes we really are so outcomes based and focused that you have to justify the money spent, the time spent, whether you should continue doing it. We don't know. We believe, right? Some of this is you have to believe.
We're testing.
Yes.
We're an experiment.
Yes. So, but to have the experience of being able to just reach out to people, not as a physician, but as just a person they know, and just ask them questions about what type of experiences in healthcare made you feel good? Like, what types of providers made you feel welcome? What situations made you feel important? And how can we help to mirror that in our own organizations? And then also, how do people get information and share information? My husband often tells me after we've been out to dinner that I don't remember that people don't talk about breasts in their normal life as much as I do. And I really need to tone it down with all the boob talk, But it's true, and particularly because breasts are not, it's not your heart or your kidneys. There's a little bit of still people kind of clam up a little bit about it. How do we get people to just speak more about it? Sisters, moms and daughters, grandparents, people that have been through breast cancer and still don't even talk about it in their own families, when they are probably one of the most trusted sources of information. How can we foster that? And to be able to sit and have conversations with each other with all these varied experiences and to brainstorm about how to bring that about has been just one of the best things that I've been involved in. So I've become a huge fan of this process, and I think it could have a huge impact in other realms of healthcare, trying to figure out what the people need instead of deciding what they need and expecting them to come get it. So that's pretty much what I have.
Are you guys ready for some questions? I'm gonna let you pass the mic. Okay. I will do a roll call. Okay. Any questions? Question.
Thank you. You talked a lot about the usual suspects. Would you expand upon that for us?
Yeah, so that's anyone that I think, so Dr. Cunningham mentioned that a little bit, right? Like you'll have your comfortable, community voices, and you'll just keep going back to those same voices. So it could be project by project, you're just accessing the same folks. It can be part of the problem when we talk about equitable engagement is like, well, we let everyone know what was happening, and then that's the equitable way. Or worse yet, we'll have, like for this process, you would have like an application process, right? Which is not equitable, right? There's a variety of barriers that are involved in that. So if it's the folks that are just, we just hear from them regularly, or B, they have the relational social connections where their voice can be heard on a regular basis, we want to get beyond those folks, right? So we might connect through those folks to identify the participants that would participate in co-design. But if you have that if you've been heard from reliably, it's about getting deeper. It's about hearing from the community that maybe doesn't share that same drumbeat message that you've been sharing for the last 6 years or something. So anyone doing community engagement if you know someone on a first name basis, you're probably a usual suspect. It's who isn't in the room. Those are our less usual or unusual suspects that we're looking to engage.
Let me.
Can you speak to sustainability a little bit? How is the community design impact sustainability, since that's always a challenge when you're doing these types of initiatives?
Yeah, I think one is because you're investing more longitudinally, you get a different. The organizations I work with, so I do co-design in every conceivable sort of space of public health and education and public policy. And one of the things that I reliably hear from organizations is they're sort of surprised by the level of sophistication that comes out of community if given the space and time and structure. But I think the most important outcome is I often say that the projects are less important. They're the vehicles for building these relationships with community partners, with community voices and experiences that didn't exist before. So what reliably happens in these projects is not so much the outcome of that project, it's now there's a connection with community that's led to another project, or in some of the work, co-designers leveraging now that access to, a mayor or a CEO or an executive director at a community-based organization to now bring that voice on a regular basis in the organizations that are doing this work ongoing. So they leverage it as a career advancement opportunity. Because one of the most persistent drivers to inequality is simply inequality to access to social networks and decision-making power and all those other things. So the relational connections that result out of that is equal, if not more important for sustainability than the particular project itself.
Okay. Do you want to just yell it, or?
I think that's a great idea about talking about all the, your boobs, whatever, your colonoscopy, and, I think they've done a great job of marketing colonoscopies in the last 2 to 3 years. But I was wondering, this could be a whole new icebreaker when you're having meetings. It's kind of exciting, but like, you got like a list of how to start, the icebreaker, like 5 questions, like, how have your boobs been lately, or, whatever it is. Because then once you do that icebreaker, you can just, cut in, and I come from a very small community, and everybody knows their maiden names. So, and probably how much I weighed at birth, everybody knows. And so this is very enlightening to be able to have those conversations, because I'll say, oh, did you have your colonoscopy? And we always ask after we find out someone has cancer, well, did you go in? I try to be polite, but I'm like, that's what I want to know. What were your symptoms? What did you go in at age 50, 45 and get those tests? And so this kind of is, a forefront to that. That's really exciting. So I will definitely use that as my new icebreaker.
Yeah, I would strongly recommend that. And almost everyone that knows me, if I think you're even close to 40, I'm going to say, getting your mammograms at my dentist's office, and you got a 3D mammogram, and then the other hygienists come in and they hear me talking about it, and then they ask questions. Sometimes someone just needs to bring it up, and then you'd be amazed how many people jump in the conversation or are having their own individual experiences and want to talk about it and just do not. So sometimes you just need people who will just start the conversation, and the more people that we have that are willing to do that, I think that this becomes a more natural conversation to have, and a life-saving one.
I'll just add to that. One of the models, one of the conversations of our 3 prototypes was normalizing mammograms. That was sort of the sense, and the way we went about it was actually using videos. And we actually have a video, it's 2.5 minutes long, of what to expect when you get a mammogram. It literally walks a woman through getting into the clinic, getting into her gown, getting into the tech room, and back and forth. And we've been using that, and we actually are piloting 2 tests of that, one with Neighborhood Health Source and one with Hennepin Healthcare Brooklyn Center, about using that video to normalize what that experience is. And actually, LaShonda was the one who really focused us on that problem, that issue.
Yeah, I think the other thing from the project was, because we heard even for people who are comfortable talking about their health with one another, it just doesn't come up usually. So using the project as an excuse almost, you need an excuse to yeah, I'm doing this project, so we have to talk about this, and how meaningful that conversation can be. So sometimes you do need the icebreaker, you do need the excuse, the permission to just like bring it up, and when sometimes it's not, usually it's not a natural thing you bring up, unless you're a big talking point about it.
I was really struck by your comment about how part of the miss is that patients have an expectation that doesn't get met. Can you give some advice to this group? How do we help capture that community expectation and share that back with healthcare providers? I'll say it's really interesting. I was just earlier this morning talking to somebody about community health workers. I was on a call last week, and the folks in Mankato were saying they can't bill for patient advocacy. They can bill for educating the community, but they can't bill for bringing the community's perspective back to healthcare providers, because the assumption was their job was to educate the community. What's really clear here is we need to educate the healthcare providers about the community expectation. So how can we help flip the script?
Yeah, I wish I had the golden answer to that. I mean, for me particularly, one thing that I've been trying to do, though the red tape has strapped me down, is to just start when the patients are in the waiting room with some information about what is likely to occur. For example, a lot of people are very worried about breast pain, particularly in Somali communities, that there's this thought that breast pain is the primary sign of breast cancer, when in fact it is the least worrisome symptom you can have in your breast. If I had some information in the lobby that said, did you know that most people with breast pain have nothing that is seen on imaging, the amount of time that I could save and anxiety and people thinking, well, I'm just not taking them seriously, or I don't believe that it hurts. Some of it is just managing what is likely to happen when you meet your provider. What are the most likely outcomes? What are the tests you are most likely to need and get? And just managing people's expectations from the start. And then also, I don't know how to teach people to show that they care. I know that some doctors struggle with that. They're too worried. They don't touch the patient's arm, you know, and I do that all the time, even if I'm just saying goodbye, or I just sit and listen to them, even though I know what they're about to say. I don't know how teachable that is, but I think sometimes if we'd focus on showing that you care, have the medical stuff in your head, but the thing you need to convey is that I'm trying to do the right thing for you, not convincing the patient that what you're doing is the right thing. And we spend too much time trying to convince them in medical words what they need and don't need, instead of showing in less tangible ways that you care about them and you're trying to do the right thing. And if I could teach that, I don't know, I'd have a whole other career.
Okay, last question, I think, and then you guys will stay around for a few minutes.
Sure.
It's great work. I'm actually working on a digital health navigation. I'm a gastroenterologist, by the way, but there's a digital health navigation tool for colonoscopy. And I'm curious, when you're designing or when you've developed these videos kind of showing patients what is the process of having a mammogram, what sort of insights did you have about things that might be too much information? When I've taken some of my videos and even shown to my kids, in my first set of videos I had, the kids were like, gross, I don't want to see that. Because I had like some endoscopy video. It's like, this is what it looks like in your colon. They didn't want to do that. Made the whole thing into cartoons. I've had those kinds of feedback from other patients and things I've worked with of, it's too much information. It's going to freak me out rather than empower me.
Yeah.
We made two conscious decisions when we did this. One, that the only people in our videos would be real people in the community that you might run into the grocery store. Hence, LaShonda, we have, everybody on our team actually made a video. We did not script them. We had a basic script, but here's what we want you to talk about. And we did a down and dirty. They're not overproduced. We literally shot at Regents Breast Center, walking in with a handheld camera. So those are the things that made them, and I will tell you the expectations video, we've shown it, and then we had a survey, and I think everyone we had 25 women look at it, and they're like, oh, I didn't know how easy it was. It doesn't hurt. Oh, this is great. I'm going to share it with my friend. So that's how we did those. We also, the other caveat for our program was we would, as often as possible, hire from the Black community, whether it's a videographer, a sound tech, an event planner. We are going to live what we are doing by working with the Black community. So,
I think kind of glossing over the parts that don't need to be gone into detail, it's not a video for residents or medical students, oh, and then you'll lay peacefully as your doctor does the procedure, I think it's very helpful. I think a lot of it is people are just, then they start focusing on that and they think, well, that's gotta hurt, and just focusing on how it's gonna feel more than what it's going to be.
Right.
I think is important.
so with that, I'm going to close up just because I love these two people, and they'll outside they can answer questions. But you go breastcancergaps.org gives us a sort of synopsis, and we have a YouTube channel, Breast Cancer Gaps, and you can see all the videos we're talking about. So thank you all.
Thank you.